everyone, and welcome to today's webinar. This is Rick Import for Orchard Software, and our session today is Do More with Less, Ease the Burden of Staff Shortages, and Boost Lab Productivity. And our presenter today is Kim Futrell, Senior Strategic Marketing Manager with Orchard Software, and we are thrilled to have Orchard, of course, sponsor today's event. Kim is currently the Senior Strategic Marketing Manager at Orchard Software. Kim has a bachelor's degree in biology, is an ASCP certified medical technologist, and has a Master of Science in Health Informatics. After more than 20 years as a laboratory manager, Kim worked as operations manager for a multi-specialty physicians group, helping them merge with a local hospital prior to transitioning to Orchard Software in 2012. With Orchard Software, Kim is a contributing author for numerous laboratory-related magazines and Orchard's white paper series intended to educate and inform laboratorians of current relevant industry topics and promote the value and importance of the laboratory. So it is an absolute delight to be working with Kim again, as it always is. Kim, welcome to you.
Thank you, Rick, for that wonderful introduction. And hello, everybody. So good to see you. How many times have you heard the term do more with less? And how many times have you been asked to reduce your budget? And how many new staff members have you trained dealing with staff shortages? And struggling with all of that, we still need to keep up our laboratory's productivity. So that's kind of what we're going to talk about today. If we look at our objectives, initially I'm going to talk about the trends that are taking place in both the healthcare and the laboratory market that relate to our topic. We're going to look at some of the reasons why we continue to have a shortage of trained laboratory professionals and look at some staff recruitment and retention strategies that other laboratories are using. We're going to look at some tactics that successful laboratories are using to actually thrive in this ever-changing environment. And then lastly, we're going to look at the value of your LIS and how you can maximize it as a productivity tool with a little bit of a deep dive into auto verification, which is one of my favorite things. So, looking at our climate, our terrain, what's going on in our healthcare and laboratory industry, we continue to see vertical integration in healthcare. Industry consolidation continues even as we deal with a pandemic, with the ownership of physician practices by hospitals continuing to increase, and with now 40% of physicians being hospital employees as of 2020. And the reason that this is happening is because these organizations are looking for that negotiating power that they can build up with payers, plus their service line enhancements and cost savings related to purchasing discounts and pooled administrative functions. But the consolidation of these large hospital networks and the closing of the physician groups impacts the related laboratories, with some laboratories being forced to close as their services are taken over by the in-house hospital laboratory as part of a merger. And I can speak directly to this. I was involved in this. I worked in that multi-specialty lab for 20-some years, and then the hospital across the street bought us, and so our laboratory slowly over several years was closed down and taken over by that hospital lab. In spite of the advantages that we are supposed to reap from this vertical integration, studies are not showing that we improve efficiency, reduce costs, or have better care. The studies are actually showing that the consolidation is increasing pricing and not improving the quality of care. So for example, there was a study here. This is a review of 2013 through 2016 Medicare fee-for-service claims data, and they looked at the effect of hospital ownership on physician practices and how that impacted Medicare reimbursement rates. And they studied 10 common diagnostic and laboratory tests. And in their study, they found that when an organization was hospital-owned, imaging went up by volume 26.3 per 1,000, and lab referrals increased by 44.5. And conversely, in a non-hospital organization, imaging decreased by 24.8 and lab referrals decreased by 36. And so this culminated in a reimbursement increase of $6.38 per imaging and 57 cents per lab test. So in spite of what we expected, with hospital-based services, Medicare reimbursement increased after integration, And that 57 cents may seem like a small amount, but if you add that up across a high volume nature of laboratory testing and imaging testing, this translated into a $73.1 million more spent in Medicare spending for those 10 imaging and lab testing that were studied during that 4-year period. We also, COVID-19 did not halt healthcare merger and acquisition activity and could be a catalyst for more continuing consolidation. COVID really forced healthcare organizations to look at nearly every single thing about their facilities, and many providers actually faced financial difficulty during the pandemic and perhaps looked at a merger as a result of that. Specific to COVID, consolidation was a bit of a pro for patients from the aspect that they could combine their trips and reduce exposure. And so we saw in 2010 there were 74 mergers and acquisitions announced. 2019 this bumped all the way up to 92, and then in 2020 dropped back down to 79. But of those 79, there was an increase of mega mergers between 2019 and 2020 from 3 up to 7. And a mega merger is defined as a merger that involves two companies that have more than $1 billion in annual revenue. So there's also been an executive order recently that is investigating hospital consolidation. They're concerned that these mergers are harmful to patients, and so they've asked that the Justice Department and the Federal Trade Commission review the merger guidelines and make sure patients are not being harmed. They're concerned particularly about rural communities not having convenient and affordable health care services. So these are quotes from a White House fact sheet. And then for those laboratories that do consolidate, what they're going to look at is your test menu. You're going to be consolidating your test menu. And another big area is outreach, because reimbursement, specifically the fact that there are no longer better rates given to large healthcare system as compared to commercial labs, means that simply maintaining an outreach program is sustainable. So the options that are kind of on the table are to strategically grow your outreach program, to reprice your outreach labs and renegotiate with the payers, or many laboratories choose to monetize their outreach program and let a national laboratory take that over. And then we also are PAMA was initially expected to reduce about 75% of our lab test reimbursements. They estimated that that would be $670 million that first year, which was a 10% decrease from our current fee schedule, and they were expecting cuts all the way through 2022. PAMA was also expected to cause more industry consolidation as laboratories try to get that economy of scale to be able to withstand the reimbursement cut. What's actually happened with PAMA is that the move to private payer-based rates led to a large decline in routine testing, just like they expected, but then not for newer high-cost tests like your genetic and molecular tests. And so for a lot of laboratories, this kind of balanced out their overall reimbursement because a lot of laboratories are doing more molecular testing. The fee schedule spending and utilization increased for independent laboratories, but decreased for hospital outpatient and physician's office labs. And then the CARES Act delayed PAMA reporting, the CARES Act being the coronavirus, God, I'm blanking on what the CARES Act stands for. Anyway, the CARES Act delayed PAMA reporting, and so the second round of reporting is not due until next January, from next January through March. And until then, our Medicare payment rates are still determined by the data that was collected back in 2017. The 15% cuts that were dictated by that initial gathering of data are not becoming effective until January of next year. And then there's a 15% cap from 2022 to 2024. And CMS is going to use the data that they collect next January for the fee schedule that will be in place for 2023 through 2025. And then on top of all that, we have a pandemic. And so a lot of the laboratories that were testing for COVID-19 had to quickly ramp up their ability to do COVID testing. And they, at the same time they're trying to do this, they're dealing with all types of supply chain shortages, anything from pipettes to personal protective equipment to reagents. And so because of that, a lot of labs had to do COVID-19 testing on different methodologies, on different analyzers. And then conversely, some laboratories actually who weren't doing a lot of COVID testing saw a decline in their regular testing because the patient's not going to the doctor. And so they were dealing with the potential for layoffs. And so it really had a big effect on the laboratory. And Melissa, the director of the Clinical Molecular and Microbiology Lab at UNC Medical Center, summed it up really well. And she said, never before in her career and probably in the history of lab medicine has there been such a spotlight on the laboratory. And the spotlight on the lab has been a highlight of the pandemic. All right, somebody helped me out here in the chat and said, thank you, Dr. Todd. It's the Coronavirus Aid, Relief, and Economic Security Act of the CARES Act. So I just was blanking on that. So I appreciate the assist there. So COVID-19 did bring some much needed recognition to our, and I actually saw a news story on our local news channel about medical laboratory scientists, which was really refreshing to see that because I'd never experienced anything like that in my career. But at the same time, it also added an enormous amount of stress and pressure to a profession that's already short-staffed, already feeling overworked. So we'll switch gears and look at that laboratory professional shortage that we've been dealing with just for decades it seems like. And there's a great quote in Becker's that are pretty well. Labor shortages in clinical testing labs have existed for years due to factors that include low recruitment, an aging workforce, and relatively low pay for medical lab technologists compared to that of other healthcare workers with similar education requirements. And so I have a poll question here. I'd like to hear from you on this. Do you feel that the medical laboratory scientists and medical technologists in your lab receive lower pay compared to other healthcare careers with similar education requirements? And are you struggling to maintain a full staff? And as answers, we have yes, no, or not sure. And so you can go ahead and answer both of these, and you want to click in that circle to the left of the text, not on the text itself, and then make sure you remember to click that submit button. And I'm going to keep on rolling through the webinar, and as soon as those WebEx has a chance to tally those, I'll share those results with you. So we continue to see a drop in qualified medical laboratory scientists that does not meet the demand for new scientists as our older generation finally gets a chance to retire. We continue to see more and more non-certified people that are allowed to perform low to high complexity testing, which is in many cases concerning. And we see a lot of lab staff taking on all kinds of responsibility, wearing many different types of hats, so to speak. And this is creating a significant labor gap between the number of medical laboratory scientists that we need versus the availability of trained professionals. The medical laboratory science programs are training only about a third of what we need, with about less than 5,000 people graduating each year from accredited training programs. The Bureau of Labor Statistics projects that demand is going to grow 7% from 2019 through 2029, which is almost double the average for all other occupations. And so you can see down in the image in the light blue, that's the clinical laboratory technologist at 7%, and in the red is the average growth for all occupations at 4%. Okay, so let's go back and look at our poll. And we have a whopping 78% that believe medical science receive lower pay than other people in healthcare with a similar education. And then an even higher, whopping 83%, laboratory has struggled to maintain staff. And I can certainly relate to that. At one point, the girl that we had training our lab staff came to me and she said, do you realize I've been training people for 2 years straight and I need a break? And I was just shocked. She really did need a break. And so a lot of labs face that we're just continually training people back to back to back, trying to keep our staff our lab fully staffed. And yet we continue to see a decrease number of medical laboratory science programs. It's declined 25% since 1990, dropped 7% in the last 2 decades, with 263 schools in the year 2000, and then 235 schools in 2020. And we still kind of maintain that average of 7% vacancy rate. And this vacancy is particularly evident in rural areas and in states that don't have any training programs, but it also affects some highly populated areas like Florida and Arizona that have a high population of elderly that require more healthcare services. And then also, the Bureau of Labor Statistics estimates that we're going to need another 35,000 jobs between 2018 and 2028, and this does not include the number of jobs that are going to become open by people who retire. So this is not going away. There's not a resolution, around the corner here. So why are our schools declining? I found this quote from Lisa Crimmins she's a clinical assistant professor at UNC Chapel Hill, and I thought she summed it up pretty well. These programs are expensive to offer, so when we're looking at that budget cut, and we look at it every year, what can we cut out? What can we not do anymore? These programs are expensive, and then they have low enrollment, so there's not that much interest in the medical laboratory profession, and so it becomes an area that they try to cut. So we end up with an aging workforce that requires more and more specialized training and fewer schools that are doing that training because of low interest. So kind of to summarize some of the factors that are attributing to our medical laboratory science shortage, as I said, the baby boomers finally getting to retire. There's an increased demand for laboratory services. More and more technologies are being added, like molecular and genetic testing, and then our vacancy rates exceeding the number of graduates. It's also difficult to retain laboratory personnel because it does sometimes feel like a job where you don't get appreciated like you feel you should. And I'm on this Facebook page of medical laboratory technologists, and there's just a lot of feeling of not being appreciated and feeling of being overworked. And so that's really rampant, I feel like, in the profession. And then we also have insufficient job classifications. There may not be a defined career ladder beyond bench tech and lab supervisor. And then many labs don't have the funding for continuing education or tuition reimbursement. There was an ASCP survey that also looked at technologies that are causing staff changes. And so the numbers in the bar graph indicate the number of participants who said that these new technologies are changing their staffing needs. 44% who indicate that molecular testing is affecting their staffing needs, 43% at automation, 35% the laboratory information system, 15% point of care testing, and 14% EMR. So these are the areas that are new knowledge-based areas for medical laboratory science. These are exciting new developments in technology that are improving our patient care. We're having more preventive testing, a focus on that, a focus on faster results and point of care testing, which is certainly great for our patients, but also means that we need new knowledge and skill sets that haven't been expected in the past. That same survey took a look at what are your top laboratory workforce concerns, and the top one, just like we had looked at in our survey, we need better salaries for laboratory personnel and an increased effort in heightening the profile of the profession, and I completely agree with that. Second biggest concern in the survey was being able to staff the laboratory with qualified laboratory professionals. They're just not out there. They're hard to find, so there's competition to get them. And that was the next question on the survey. What are your top hiring challenges? And it's better pay or benefits at other laboratories, competition to get those well-trained people, and then the people who are applying for the jobs don't have the necessary certification, education, or skills that we need them to do the job. And then on top of all that, COVID-19 brought along a record new number of CLIA laboratories with more than 24,000 new CLIA labs in 2020, a 50% jump from 2019. And these new labs are all over everywhere. There were more than 7,000 in physician offices, more than 3,500 in pharmacies, more than 2,900 in assisted living facilities, and then another 3,300 plus in the category of other. And other includes dental offices, substance and abuse and addiction facilities, sports stadiums, fire departments. There were 979 new CLIA labs at schools and student health centers, and 361 new mobile labs. And then also of interest here, I thought CMS is also cracking down on the labs that don't have proper certification. And they issued 171 cease and desist orders in the end of last year for labs that either didn't have the right certificate or were performing outside of their certification. So it'll be interesting to see going forward what happens to these labs that popped up and the big volume of PCR testing capacity that was ramped up for the pandemic as that testing demand declines. So laboratory scientists have been on the front line since the pandemic. They're our healthcare heroes, but the pandemic came on top of a career that already faced a lack of properly trained scientists. So it's been stressful. In many healthcare organizations, shortages have caused the people who are still at work to carry out the same volume of tests as a fully staffed lab, because we know that we still have to hit the turnaround times. The samples are only viable for the amount of time that they're viable. You can't just wait until next Wednesday when somebody's there to get it done. You have to get it done because we're all focused on patient care. And so this leads us to working overtime, to working double shifting with skeleton crews, and still being expected to hit those turnaround times. And this can lead to that kind of mood that I was talking about on the Facebook group, that they're exhausted, burnout, and then of course that increases the potential for error. So this has really been a perfect storm that's kind of come upon us in 2020, 21, and where we're shifting to value-based care. We have industry consolidation really coming to a peak. We continue to have workforce shortages to the point where it's really becoming a struggle across the entire profession. We have new technology demands that are changing our skill set that we need. And then we have a pandemic on top of everything else. But incredibly, there are successful laboratories that manage to adapt and change and flex and do whatever they need to do. And as part of the way they do this is by leveraging as many tools as they have at hand so that they can continue to contribute to patient care within their organization. And so let's talk about that. How are these successful laboratories adapting and thriving? We know there's competition for those most well-trained medical laboratory scientists. To retain those top employees, we need happy employees, and our job satisfaction is tied to our workload, our recognition, our feelings of value, and then also, of course, our salary. So some strategies to recruit and retain staff. And I'm sure many of you have a lot of these in place, but flexible scheduling, can you do 4-10s? Can you do 3-12s? Can you alternate shifts? Money always is a great incentive. So can you afford a relocation or a sign-on bonus? Can you put in place tuition reimbursement? A lot of us in the lab are lifelong learners, and so furthering our education is a very exciting endeavor. I know it was for me. And then, of course, we need to have lucrative benefit packages, career advancement options, and then continuing education or training opportunities. So ASCP and the University of Washington Center for Health Workforce Studies, they collaborated to study the clinical laboratory workforce shortage. And their goal was to try and find some strategies to begin to recruit new medical laboratory scientists. And they came up with these 3 top kind of goals or strategies here. The first one being to improve the visibility of the profession. And their idea here was that we start introducing medical laboratory science careers at the elementary level, and then we provide tuition support and more scholarships. Secondly, to improve workforce recruitment and retention, which is what we were just talking about. They had many of the same ideas we've already presented: flexible schedules, benefits, tuition incentives, sign-on bonuses. But then interestingly, they also said we should offer incentives to lab employees who attend recruitment and awareness building events, and then offer financial incentives that encourage professional development and job satisfaction, plus provide opportunities for career growth through tier levels, pay increases, or elevated titles. And I thought those were additional good ideas. And then third here, to promote diversity and inclusion within the laboratory. And so now we're going to take a look at some of the innovative solutions that other laboratories have come up with to kind of deal with the shortage that we're facing. And this one's at the University of Minnesota, and they have a medical laboratory science program there, and they were struggling to train it and, looking at closing their program. And instead of doing that, they were able to reduce the time that medical laboratory science students spend in their clinical rotations. They were able to reduce it from 22 weeks down to 12 weeks. And this was not to shortchange the students. This was to ease the strain on the sites that are actually providing the training. And so they were able to do that. And then next year, they're planning to take that even further, even though initially they did this to deal with COVID-19. But it's turned out to work well in their science program. And then recruitment strategy, Alverno has a big fat sign-on bonus, and they are offering $10,000 for medical technologists, medical laboratory technicians. They have 288 open positions that they're struggling to fill. And it says right here, trouble filling positions because of a lack of qualified applicants. And so we're feeling that everywhere. And this was from July's Laboratory Economics, if anybody's looking for that. Then a retention strategy example, this is at the University of Vermont Medical Center. They realized that that training students and new hires was a concern for them, that there are preceptor programs for nurses that are very common, but they couldn't find a preceptor program for the laboratory, and so they created their own lab preceptor program. And what they did is they trained their technologists, specifically gave them the tools that help them be effective teachers so that they knew how to train new hires and students rather than just kind of winging it like most of us do. And what this entailed was a 4-hour workshop that they offered at different times so they could accommodate staff hours. They taught them the VARC learning styles, which is visual, auditory, read, write, and kinesthetic. And by doing this, by giving them these tools and teaching them how to teach, these technologists were really much happier and more satisfied in their jobs because they felt more effective and they felt more valuable. And they were doing a great job teaching their new students. That was my favorite one, I think. And then a recruitment strategy example at Memorial Sloan Kettering Cancer Center. And of course, you have to be a big enough organization to pull this off, but they continue to have a shortage of trained technologists, so it pushed them to be more creative. And they are able to pull employees from other parts of their organization and put them into an internal education program and retrain them to become laboratory technologists. And then Tricor Reference Lab kind of did the same thing, but they were struggling with histotechnology training. And so they developed a histology apprenticeship program. And again, they recruit internal candidates from their employees to participate in histotechnology training. So then another area where successful laboratories are focusing is on laboratory stewardship. And so laboratory stewardship, I'm sure you're all familiar with the term, but it's basically thinking further than reporting out rapid, accurate test results, which of course is our goal, but thinking about what happens to that patient based on these lab tests that we report out. What are the downstream healthcare processes? What are the downstream tests that are ordered? What are the downstream costs that are associated? And then also assisting providers in making sure that the best tests are ordered and that those tests are properly interpreted, and then the follow-up tests are properly ordered. So it means that you take responsibility for lab testing from is the right test ordered through is the test properly interpreted all the way to what analytics are used. Can you use your laboratory data for population health incentives or to support value-based contracts? Where is your lab data needed within your organization? Then another area to consider is looking at standardization. This can improve your lab efficiency, particularly when you standardize across testing locations. Patients benefit from consistency in lab testing, It can improve their satisfaction. It can improve your overall quality and your workflow. When you have different testing methodologies, it can be confusing and can potentially lead to misinterpreted results. So if you have 3 different analyzers that report glucose, and you actually have 3 different glucoses in your EMR with 3 different reference ranges, that definitely can cause confusion. So when you standardize that, your EHR and your LAS setup becomes uniform across locations and across instruments, and you reduce those opportunities for misinterpretation. When you have standardized policies, procedures, and methodologies, everything's easier to manage. You have increased quality and efficiency because you've eliminated redundancy and you've reduced potential for errors. And then, of course, uniform purchasing standards help your laboratory to be more cost-effective. Then another area that you can consider, of course, depending on the size of your laboratory, is automation that can free up your laboratory staff for other duties, but it also can decrease those repetitive injuries such as carpal tunnel syndrome, such as that wrist pain that you get from popping the top off of 500 tubes every day. It can help you improve your cost effectiveness by speeding up your processing time. It improves your ability to track tubes. It improves your overall turnaround times and helps you eliminate the errors that are inherent to human interaction. And then all of these things together kind of culminate in an opportunity to improve overall job satisfaction, which relates back to our happy employees are the ones that are going to stay. And so that relates back to how we keep our staff. And then last section here, we're going to look at maximizing your laboratory information system as a productivity tool. So the job of the LIS is to make laboratory professionals' job easier and to allow your expertise to be focused on tasks that actually require human interaction. So when you have an LIS that you're using to its max and you're using every feature of it that you possibly can, it's intended to fully automate the functioning of your lab that helps improve your staff experience, employee motivation, and your overall lab operations. So with an effective LIS in place, your lab is integrated, connected across all locations. You have easy access to your records and your data. It can help you standardize your procedures and more efficiently use your resources. It helps you reduce errors and reduce paper, maybe eliminate paper. It can automate your reporting, reduce your turnaround time because of that connectivity, and then all of these things, again, culminate in improved staff performance and improved staff satisfaction. So your LIS basically manages your workflow management. It has audit trails and sample tracking, so you know where your tubes are throughout the full testing continuum. It allows that connectivity that allows orders to be from your EMR to your LIS, your barcodes print out, your LIS tells the analyzers what tests to perform, those test results go back to the LIS, back to the EMR, everything's automated, and data is shared across facilities. And then your LIS also has decision support rules that help standardize workflow, and these rules can be in place across the entire testing continuum, rules in the pre-analytical phase like order entry rules or split order rules, in the analytical phase like result evaluation rules, and then in your post-analytical phase such as bin to host or CPT code rules. And some examples of these rules that can help standardize your workflow and reduce errors are you can put decision support rules in place that send tests to the appropriate lab based on the insurance requirements. You can have a rule that prints the exact number of labels that you need based on what test is ordered, based on the tube type. You can have rules automatically reflex testing, like for example, an abnormal TSH can reflex to a free T4. And then my favorite, you can have rules that auto-verify your normal results. And we have some slides a little later that are going to get into that. You can put rules in place that don't allow orders to go through, that don't have proper diagnosis codes, that don't allow results to be released unless the QC is within acceptable ranges. And you can auto-deliver reports to whomever, whenever, and however you choose to. And then for billing, you can automate that CPT code attachment so that tests are billed for right as testing is complete. And so what this does for you is it reduces those sticky notes that are stuck all around the processing area monitor, all around your analyzers. You can pull each one of those sticky notes, and probably 90% of them can be created in, can be shifted into a decision support rule and then throw away the sticky notes. And then also, the laboratory has a tremendous amount of data that is vital to patient diagnosis and treatment, and this data is in there. It's just all was waiting for you, the key performance metrics you want to pull out of it, that you can help to achieve your quality goals, promote population health management, close your care gaps. You can automate reports that allow you to track your KPIs, track your laboratory metrics, things like utilization monitoring that's right there ready for your inspector, staff productivity that can help you with your scheduling planning, and then of course turnaround tracking, looking for problems where you can possibly improve in that area. Your LIS can also help you be inspection ready, particularly in regard to quality control and quality assessment. In the area of control, it of course tracks your qualitative and quantitative QC. Everything's on your Levy-Jennings graph, and you have your Westgard rules applied. Your inspectors can come in and look at your QC right on your LIS. You don't necessarily need to print out reams and reams of QC and punch holes and put them in notebooks. The inspectors can look at them right there on the screen. You can also see multiple Levy-Jennings graphs on one screen so that you can compare across lot numbers, or you can compare different analytes. And then you can also set it up to automate that weekly quality control review so that maybe every Friday that pops up waiting for you to put your documentation right in there. Assurance or assessment, you can create standardized comments for unacceptable specimens or rejected tests, and then you can create a report of rejected orders log, and then so you can look for trends or patterns and see, okay, it looks like we're having a problem over here in our cardiology building that we need to address. You can create error reports, corrective action comments, and you can do this by provider. So maybe Dr. Johnson, maybe when you create this, you see a certain doctor's having a problem with, he's complaining about all his calciums. You realize maybe you need to look into that analyte. You can track remedial action reports by pre-analytical, analytical, and post-analytical, and then of course, track that time for your time-sensitive tests. Now, my favorite section here, let's talk about auto-verification. So just a basic definition here, auto-verification is basically setting parameters up for your patient results that apply to results that are coming from your interface instruments into your LIS. And so results that fall within those parameters automatically release into the EHR without any staff intervention, and results that don't fall within those parameters are stopped, and the technologist has to review them before they're reported out. And so here's our next poll question. I'd like to hear from you. How many of you have implemented auto verification in your laboratory? And our choices are yes, no, not yet, but I would love to, like to, and then maybe you're not sure about that. And again, make sure you click that circle to the left of the text rather than not the text itself, and that you click the submit button as well. And I'm going to keep on going, and we'll come back to those. So auto verification is one of the absolute most time-saving, beneficial undertakings that a laboratory can implement. Some laboratorians may struggle with letting go of doing that instrument printout and making sure that they put their eyeball on that result transmitting properly. But once you have successful auto verification in place, the time savings is an effort. So assuming your LIS has this technology, I encourage you to use it. It helps you improve your quality, reduce your costs, simplify your processes. It allows you to provide consistent test reporting with dramatic improvements in turnaround time and a reduction in error rates. Depending on your menu patient population, 80% of your results could qualify for auto verification. One of our longtime clients here, Washington Health System, Washington Health System has two main campuses. Washington Hospital is a 250-bed facility in Washington, Pennsylvania, and Washington Green is their other 23-bed facility in Waynesburg. Each of them have a laboratory, and then they have 9 off-site for all locations. And so they implemented auto verification in their hematology area, and they're able to auto-validate about 80% of their hematology results. And so, like I said, this is going to be lab dependent. I worked in a lab. We had an oncology specialty, and so we obviously could not auto-validate many of our hematology results if they were greatly abnormal, but we could auto-validate a lot of our chemistries and our coags. So this is going to depend on it. It looks like a good deal of you on our poll have auto-verification in place. 60% of you, so I'm preaching to the choir on 60%. That's really encouraging for me to hear. I'm glad that we have that high response for that. So here's a flowchart example, just a basic look at auto-verification. You're going to test the test, measure the lab analyte. Is it in dynamic range? Is it in the reference range? Is the delta check acceptable? And are there analyzer flags? And then if all those things are acceptable, that result is likely eligible for auto verification. If any of those are not in line, then that test won't auto verify and it needs to be reviewed by a laboratory scientist. If it's not within dynamic range, if it's not within reference range, if the delta check's not acceptable, or there's an analyzer flag. So if you are kind of intimidated by auto verification, just take the process one small step at a time and find one test to begin with, determine your acceptable parameters, build those result evaluation rules, test it out on test patients when you feel good about that, test it on your real patients, but only turn it on for that one test, and then still monitor those results closely so you've verified a sufficient volume has transmitted into the EHR properly. And so we started with Proton and INR and just grew from there. So if we look at the steps a little more in depth, the first biggest one is to do your research. There are a lot of resources out there available. Certainly the CLSI, Auto 10, and Auto 15 are the biggest ones, but I have another slide a little later with some resources on it. And then look at your current workflow approval process and use it to create a basic policy for your menu and your testing volume. But remember that it can be updated as you go along, but it's always helpful to find that starting point and refer to it as you go through the process. And then probably the most complex step is this one here, defining your acceptable auto verification range. This defines the acceptable limits for a lab test that can be released without review. And so to start this, you can maybe pull LIS reports of a certain analyte and analyze that for each test and determine what are those cutoff points where you're not comfortable with that result going out without review. And you're going to look at all these things on the slide to analyze their linearity, your auto dilution procedures, panic values, delta checks, what are your quality control requirements, what flags come across for that test, how do they come across the interface, what is your rerun policy, what are the reference ranges, and do they include age and gender-specific ranges? Are there calculations that report out with that test that you also need to auto-verify? And then is this test involved in a reflex policy? And then are there integrity checks like homolysis that you need to consider? Next, you're going to create those auto-verification rules in your test system. Once you've tested enough that you're comfortable with that, you're going to create those rules in your live system, but still review those transmissions to make sure that they're accurate. Your review should include enough volume that several tests fail to auto-verify, and ideally you would like each encounter, each reason for a failure to happen. So you want one that's out of reference range, one that fails delta check, that type of thing. And you can create a spreadsheet to keep track of that and document that. You want to train your staff throughout the process, and then you have to verify your auto verification. So here are the resources that I mentioned, the CLSI standards, Auto 10 and Auto 15, and then I have 3 other articles down here as well that you might find helpful. Inspection, everything that applies in the laboratory applies to auto verification. Both CLIA and the Joint Commission requirements through pre-analytical, analytical, and post-analytical also apply to your auto verification process. And the College of American Pathologists has a specific auto verification checklist. some general rules here. The laboratory director must approve and sign the policy and procedure, just like any policy and procedure. You have to have an audit trail that has a date and time stamp of your auto verification. You need a process in place that makes sure that any test that is auto-verified has had acceptable quality control prior to being released. And then, as I mentioned, you have to verify your auto-verification initially and then thereafter annually. Anytime there is a significant change in your analytical procedures, this is like you get a new analyzer or you change your specimen handling requirements, you have to repeat that verification process. Your auto verification needs to include your Delta checks. It also must include a rapid suspension procedure so that if there's a problem in just a few clicks, you can just completely turn off auto verification so that no problem results are being released. And then it's a requirement that your quality assurance program includes something in there that evaluates your auto verification process. It's a good idea to maintain auto verification rule traceability so you can look back and determine exactly what rules were in place during each testing period. And then in summary, our healthcare industry and our laboratory just continues to change and flux, and with PAMA coming down the line, we're expecting laboratory reimbursements to decline. We continue to have technology advances that are making changes in what the laboratory knowledge-based requirements are. We have a laboratory workforce shortage that is not likely to be resolved in the near future. Hopefully we can begin to move in that direction, but I think it's going to be a while before we actually see a resolution. But on the plus side, COVID-19 did bring some well-deserved recognition to our profession, and we want to continue that momentum. So in this current healthcare, it's really prudent for laboratories to find every single opportunity they have to boost their productivity and to boost their overall efficiency. So some key takeaways that I'd like to leave you with. It seems like in the laboratory that change is just the norm. I remember when I used to finish a new procedure and then 2 days later it would be full of notes about things that needed to be updated. So I think the trick is to learn to be okay with change and to not let it cause you undue stress, to kind of be able to roll with it. So try and adopt a stance of flexibility and to expect change so that when it happens, it doesn't bother you quite as much. We also want to keep those stellar employees and coworkers, and to keep them, we need to appreciate them, make sure they're listened to, make sure that they're respected. So the challenge is to create that culture of teamwork and appreciation for each team member so your team works well together and that you all have each other's backs. And then push for those retention incentives that will keep employees satisfied and feeling appreciated. Take every opportunity that you have to showcase your lab's value and to tell others about our profession. I used to speak at UNCW, which is UNC Wilmington, at their Intro to MedTech class every year to tell them what we do. And now, since that program closed, of course, I speak at a local community college about opportunities in our field. So if those opportunities open for you to talk about our profession, maybe reach out and take them. And then take an inventory of the tools that you have in your lab and make sure that you use all of them to their full potential. This includes your LIS, which may have more functionality than you actually realize. Try not to shy away from features like auto verification because the setup is challenging, because the payoff is worth it in the long run. Make sure that your LIS end users have all the training that you can get them so the system is utilized to its full potential. And then if your vendors offer extra training classes, make sure you take advantage of that, because the better trained your lab is to use the LIS, the greater benefit it brings. And then lastly, and probably most importantly, take time for yourself and find that thing in your life that centers and balances you and fit it in your schedule so that you can face each day doing your best. And with that, I will close and turn this back over to Rick for our Q&A.
Well, thank you, Kim, and what a fantastic presentation that was. We do have a number of questions, so let's just go to our very first one. This is an interesting question. You may not know exactly where this is, and maybe you can steer Marina to the right place. Is there a compensation study that is specific to the laboratory? Would you be able to share samples of competitive benefits packages that we're able to look at?
Well, that is a great question. And I don't have, like, I wish I had a spreadsheet that had all that in it, right? And actually what I would say is that in together this presentation, I really struggled to find a lot of this data on the laboratory. It's I don't want to say it's like we don't exist, but it was really hard to pull this information. So, you know, that'd be a good project for me to try to see if I could find some of the information, but I don't know a place to get that right offhand.
Well, you might wind up being the only human who would know that after that, Kim. If the clinicals are shortened, then how would the lab employers expect the future laboratorians to know everything and have the confidence to release results for helping providers to diagnose patients?
That's a great question as well. And when I saw that initiative that they put in, that they've shortened their weeks from 22 down to 12, I kind of had that same concern. I'm like, how could you possibly cram everything we need to know in 12 weeks of clinicals? And, you know, it certainly is a concern. But I think if you thought it out really thoroughly and removed some of the fluff that's in there and really focused on streamlining it and having the tests be really focused on making sure that they retain the things that are important, the things that help them go forward in their career, that you could pare it down. But I do think it's a slippery slope, and that you need to be really, really careful in what you're keeping in and what you're getting rid of. And, you know, at least they're not closing their MLS school. They're keeping it in place and trying to shorten it. It's a concern to me on one of the other slides that we now have, you know, people with high school diplomas and people with that are not qualified doing a lot of lab tests in areas, and it's like the profession's just slipping as far as education requirements. And I don't think that's a move in the right direction. But I don't know what we do as medical laboratory scientists to change that, other than, you know, trying to promote our field. But it is definitely a slippery slope. Great question.
Next question for you, though, Kim. How do you see multiple LJ charts at once?
Well, you know, when I did this presentation, I obviously work at Orchard, and so I'm basing some of my LAS knowledge on what Orchard can do, and I'm mostly assuming that the majority of laboratory information systems have similar functionality. You know, I've seen several of them that do, but I don't know that every LAS has that functionality. But in our system, you can pull up the different tabs for different analytes, and the beginning graphs kind of lay over the top of one another so that you can compare them on the same screen.
Okay, thank you. Does auto verification have to be an all or nothing option? How can we single it out to one test or department?
It absolutely does not have to be an all or nothing. And like I said, we were terrified of auto verification because we like to hold that piece of paper, walk it over to the EMR, and look at that result in there. Yes, it matches. And I had some older techs that were really just not wanting to let go of that paper. So we started with just ProTime and INR. And it took us forever to feel comfortable releasing those, auto-verifying those. We looked at them ad nauseum, but after we looked at them over and over and over, and there were no errors because we had covered every aspect of you know, all the potential ones that we did not want to auto-verify, we got more comfortable with it. And then as we added in other analytes, we kind of got a little faster and faster as we got a pattern into what we were going to do. But yeah, I mean, you could just do one section of your laboratory or one test. Anything that you could do to make your turnaround time faster and increase your efficiency and free up your staff is a plus.
Excellent, thank you. Just had a rash of questions just come in. So let's take one more for now, and then we'll come back to some more. Actually, this is a comment from Kathy that she's helpful information. She says, CAP removed the annual testing of auto verification It changed in June of 2020.
Oh, yeah, good to know. Thank you.
And next, how can we, you know what, before we go on to this next one, I just looked at the time here, and we are 2 minutes away from our scheduled stop time. So we do have a number of more questions that we will come back to, but we do realize that some of you may have a hard stop on the hour, and you need to get going. So if you need to get going, we thank you for joining us. We hope you stay safe. For those of you who can stay with us, though, let's move to our next question. How can we verify initially and annually auto verification for quality assurance?
Well, okay, another great question. It's not an easy answer, but you're basically doing your initial verification as you go along, as documenting those tests that you're making sure transmit properly into the EMR and making sure that the ones you don't want to transmit did not. And so then annually, I mean, if you kept that spreadsheet of these are the ones we don't want to transmit into the EMR for these reasons, then at your annual verification, you can go back and just review. You have to choose your number based on your volume, what's a significant number to review. Just verify that they went properly, and that will verify do your annual verification. As far as your QA, in your overall quality assurance plan, you want to have something in there that touches on your auto verification, something in there that reviews your auto verification process.
Okay, thank you very much. I am in the process of copying and pasting all of these questions. We'll get to as many as we can. This is a follow-up question. Does market analysis show that we are in a crisis shortage of CLS? Any thoughts? And there is another one that points to the nursing shortage as well. I'll see if I can find that, and we'll approach that one next. So do any market analyses show that we're in a crisis shortage of CLSs?
You know, I don't know if I ran across the term that we're at crisis level, but there's a lot of information out there about the statistics showing a dire shortage, and that we continue to expect that to get worse and worse. I think we got saved a little bit there from where a lot of people were expected to retire in the past 5-6 years, and they couldn't because of the drop in the stock market. So a lot of people worked longer than they intended to, and for some reason, somehow we continue to be able to function short-staffed. I don't know how we do it, but it is expected to get worse and worse as we go forward. So is the answer going to be that we pull in people that don't have an education and allow them to do lab testing, and the certified medical laboratory scientists are only doing, you know, the molecular and the genetics and the more complex testing? I don't know where it's going to go, but it doesn't look like it's, you know, going to be solved quickly. But I think it's coming to a crisis, but don't have the documentation really to prove that.
Well, thank you, Kim. And I'm going to give you control again and read this question so that you can help Teresa with this. Can you please post the reference list for auto verification again? So if you can pop, I've given you control so you can click over to that slide if you can.
Sure. Oops, went too far. There we go.
Perfect, thank you. I'll leave that up there for a while. And I will take the ball back here, yes, so I don't forget. There we go. And next, have you seen a 2-year MLT program with easy transitions to a 4-year program?
I don't know one to name offhand, but I do know that is an option out there at some schools. My daughter actually was looking at going to MLS school, and she changed her mind there at the last minute. But that option is out there and available, and I think is a good option if we could. And there's some too that start in community college and then end up doing clinicals at an academic center. So we are getting more options in the medical laboratory science school program.
Yeah, and many community colleges do have a 2-year program that transitioned to a 4-year in-state program, just straight without any exams or anything. So next, the nursing shortage has national attention. This is a statement, and I'm glad. It's just great to see how people really recognize this and want to take a stand here. The nursing shortage has national attention. We need that national attention as well as attention from Congress for scholarships, grants, etc., and the schooling paid for with a promise to practice in underserved areas.
Yeah, totally agree with that. And my other daughter actually is a nurse, and it's somehow it's like that the Board of Nursing is just really pulled together as a strong entity, and they take a stand, more so than the laboratory has. I think maybe we're coming in that direction, but absolutely those are the types of things that we need in place to get this going in a good direction.
Somebody raised those daughters right.
My husband is a computer scientist, and he's like thinking we're totally on the wrong side of things, all three of us.
Yeah, we don't think so. Next, is there a possibility on a streamlined salary that may be comparable to all MTs and MLTs, regardless of the state where the pay difference is not significant, versus other healthcare professionals, especially with the amount of education that we require? A streamlined salary. Maybe you don't mean streamlined. You may mean a sliding scale, perhaps? Well, we'll come back to that if we can. And can you give examples of tier-level job titles?
That's a great question too. And as I read that ASCP University of Washington workforce where they suggested that, I was thinking to myself, well, I guess we're just going to kind of have to create some titles here that maybe necessarily don't exist. But what we've done, some things we've done in Orchard are they're not lab titles, but in our tech support, we've created 3 different tiers of tech support, and you come in at tier 1, and then you have to go through more training to get tier 2, and even more training to get tier 3, and those 3 levels have different pay. So I feel like we could do something similar in the lab, where you come in as a bench tech level 1, and then you move up to 2 and 3, but you would have to qualifying requirements either in further education or continuing education or time, experience time that is required for you to move up the tier ladder.
Well, the truth of the matter is we need more laboratorians, and we need that to happen very soon. So thank you all so much for your contributions, your ideas, your suggestions, your questions, and let's wrap things up here, as they say. And a big thanks to you, Kim, for just a fantastic presentation and all these responses to these questions. It's always a delight listening to you. Thank you.
Thank you.
And a big thanks to our friends at Orchard for sponsoring this event. We hope that you'll join us again for another Orchard-sponsored webinar. And a big thanks to all of you for joining us today. We hope that you will do that again very soon, but also hope even more so that you stay safe and healthy and we get through the rest of this unscathed. Thank you for all that you do every day out there on the front lines, and hope that you stay safe, as I said. So thanks for joining us, and have a great rest of your day. Thank you, Kim. Terrific presentation. Bye-bye, everyone.